Okay, so first of all, we have to thank our sponsors who make these programs possible. Supernus, Adamas, Kiowa Kirin, Boston Scientific, and Amneal. We thank you so much for your support. The mission of the Parkinson's Foundation is to make lives better for people living with Parkinson's today until there's a tomorrow without the disease. And we fulfill our mission through what we call our 3 pillars, which are better care, research, and education and advocacy. Our Center of Excellence Network is a group of only 47 centers worldwide that exemplify research and care, and as well, we work with many fabulous centers and a lot of groups all over the world in various capacities and partnerships. So some of you here actually might already be familiar with these educational materials. Show of hands or write in chat if you have our Aware and Care Kit or any of our books or resources. Awesome. So you can order those by calling our toll-free helpline, which is 1-800-4PD-INFO. And those resources can also be found in the digital format by going to parkinson.org. The Foundation's newest research project is called PD Generation, and it is a free at-home genetics test for people with a confirmed Parkinson's diagnosis. We are also going to share that information in the chat so you can look at that, and the website is parkinson.org/PD Generation. Another show of hands or write in chat. How many of you have been to Moving Day in the past? Either to Moving Day LA or, yeah, Moving Day Ventura. This year, Moving Day Ventura is virtual, and Bernice Dedig is the walk coordinator. She's here today, and you can chat directly to her if you have any questions about doing that this year. So we hope you'll stay connected to us on our website, the social media channels, and of course through the helpline by phone and email. Today we're going to learn about sleep and Parkinson's disease, and many of us on here already kind of know a lot about Parkinson's and maybe even about sleep. But some of us on here might actually be new to a diagnosis. So we're not going to start with a Parkinson's overview today, but if you would like one, we're going to share a link in the chat so that you can copy and paste that or make a note of it and watch it later. Also, if you do have those specific Parkinson's questions, you can always reach out to the helpline or visit our website. Okay, and with that, I am very happy to introduce our first speaker today. Dr. Bradley Heiner of Dignity Health in Oxnard attended medical school at Ohio State University and completed his neurology residency at Stanford University. He is a board-certified neurologist specializing in the care of patients with movement disorders and believes that high-quality care must be individualized and addressed in a caring and supportive environment. Dr. Heiner's research interests include genetics and Parkinson's, and you'll find his office details in the chat. And welcome, Dr. Heiner.
Great, thank you so much for having me. I think these Zoom meetings, while it's ideally we'd be getting together in person and sharing and caring, but this is pretty darn good. I think you guys have done a wonderful job at getting these programs coordinated. I am a neurologist. In fact, I am a movement disorder specialist, and movement disorders, when you say movement disorders, that what that amounts to is largely Parkinson's disease, but also some other conditions which can cause problems with tremor or impairment of coordinated movements. And I want to say right off the bat, I'm not a sleep specialist per se. There are neurologists out there who have undergone specialized training in sleep disorders medicine. I am not one of those doctors, but I know enough to kind of get by. And certainly sleep problems being so common in Parkinson's, you really can't ignore that as a topic. So I'm going to walk through a whole bunch of material. It's really quite a fascinating area. And we will start with, okay. Well, sleep disorders are so common. It's not necessarily just a Parkinson problem, of course, and just everyday life. You'd be hard pressed to find anybody who's never had a problem with getting a good night's sleep. And these are just some statistics that in the normal adult population, you see up to a half or 33 to 50% of individuals will have some difficulties with sleep problems. And, you know, that translates to real health issues, increased risk of depression, anxiety, substance abuse, et cetera, et cetera. So sleep disorders are critically important to our lives. Talk a little bit about normal sleep physiology. And sleep can be roughly subdivided into two main categories. There is rapid eye movement, or REM sleep, and we have non-REM sleep. And there are 4 stages of non-REM sleep. Those neurologists who specialize in sleep disorders will talk about something called an all-night sleep study, or a polysomnogram. And the polysomnogram monitors a whole variety of vital functions, including your brain waves. And brain waves can be classified based upon the state of the person. So if I'm awake and alert and I'm talking, and as I am now, fully engaged, my brain waves are going to show a very specific pattern, which we can categorize based upon the frequency of the brain's electrical activity. And normal adult awake brain waves run in the range of, and this would be, frequency is categorized by hertz, or cycles per second. And when we're awake and talking, our brain waves are running at a rapid pace, up to 100 hertz, or cycles per second of activity. Sleep is characterized by a stepwise slowing of brainwave activity until we reach what's called slow wave, or deep sleep, and that would be stage 4 of the non-REM sleep stages. Talking about non-REM sleep, or non-rapid eye movement sleep, are those stages where we really get our most restorative rest. So as we pass into the slower and slower wavelengths of sleep, into delta sleep, which is a very slow wave activity, that's where the body repairs itself, regrows tissues, builds bone and muscles, strengthens the immune system. So getting adequate deep sleep, stage 3 and 4 sleep, is really critical for restorative capacity to occur. As we get older, irrespective of Parkinson's disease, but just getting older, a couple of things occur. One is that we don't require as much sleep. We all have probably heard about getting a good 8 hours of sleep is necessary to have a fully refreshing sleep. As we get older, we don't spend as much time in those deep stages of sleep. And so, you know, just as a result of aging, we're already kind of cutting short some of that restorative activity. Rapid eye movement sleep is of particular importance in Parkinson's disease, and I'm going to go into that a little deeper in a few minutes. But rapid eye movement sleep is your dreaming sleep. And dream sleep occurs in a cyclic manner throughout the night, where you pass through the different stages of non-REM sleep, 1, 2, 3, and 4, and then you enter REM sleep. The first period of REM sleep is relatively short, about 10 or 15 minutes, and throughout the night, the REM stage gets longer and longer. And this would be our dream sleep, where we may experience very vivid dreams, in fact, even scary dreams or night terrors, but your brain during REM sleep is actually quite active. So whereas non-REM sleep is characterized by slow wave activity, REM sleep is like all of a sudden you've awakened the brain. It's very active, but at the same time, in order to have good REM sleep, your body has to be quiet. and that is a phenomenon called atonia. It turns out that when we enter dream sleep, the reason we don't all jump and jerk and kick and act out our dreams is that our brain, specifically the area of the brain called the brainstem, which is deep underneath in the back of your brain, the brainstem has kind of a switch that turns on, and that switch allows your body to remain restful while your brain remains is very active. As I noted here, babies spend a lot of their night or a lot of their sleep in REM sleep. And so if you have a chance to look at a baby who's sleeping, you'll see that his or her little eyelids are fluttering and the eyes are moving all around underneath the eyelids. And that's an indicator that they're having REM sleep activity. This is sort of a graphic way of presenting what happens with our sleep cycles. Within the first hour, hopefully we fall asleep. We pass through 1, 2, 3, and 4 stages of non-REM sleep, and then the brain kind of wakes up, and that would be the upslope. And the REM sleep time is in gold in these in this graph. So we pass through REM sleep, and then we go back down again through the stages of non-REM sleep, and this cycle repeats itself throughout the night. And in order for us to wake up feeling refreshed and we're ready to conquer the world, you really have to go through these cycles on a very regular basis. The problem is with sleep fragmentation, which is the term that we use commonly for Parkinson patients, this nice cycle up and down doesn't occur as it should. Aging changes in sleep. Patterns change. We get something called DIMS and DOEs. DIMS is disorder of initiating and maintaining sleep. That would be you folks who have trouble falling asleep, trouble initiating sleep, but then very common, in fact, on your poll this afternoon, Sarah, the most common complaint was of difficulty staying asleep or maintaining sleep. And as a result of either DIMS or DOEs, then you can have excessive daytime sleepiness, or EDS. As I mentioned previously, total sleep time is typically decreased a bit as we get older. There's less time spent in that deep, restful, dreamless sleep and frequent awakenings during the night. Now, this is an important point. Let me take a sip of water. Parkinson's disease, the motor symptoms of Parkinson's, tremor, rigidity, bradykinesia, and so on. The motor symptoms of Parkinson's rarely awaken a person at night. It can happen, and for those relatively rare individuals where they wake up at 2 or 3 in the morning because their tremor has resurfaced, for those folks, taking a dose of Parkinson medication, and I typically use Sinemet CR or carbidopa levodopa extended release, 5200 at bedtime. But most people with Parkinson's are not awakened in the middle of the night because of their Parkinson's. And for that reason, people are always surprised to hear this. For most patients, a dose of Parkinson medication at bedtime is a waste of a dose. It's a waste of a pill. You don't need it. And the interesting thing is, when we fall asleep, our Parkinson's disease falls asleep as well. So if you can't fall asleep, if you have trouble initiating sleep, get out of bed, do a quiet activity, reading, listening to music. When you start to feel sleepy, get back in bed and try again. And you can kind of rinse and repeat that cycle. One very important note is that while people tend to think of alcohol as a sedating substance, in point of fact, it's a horrible sleep medication because it causes frequent awakenings during the night. Alcohol is a very bad thing for individuals who have sleep disorders. And certainly avoiding alcohol after 6 p.m. would be wise. So what can you do to kind of help with what we call sleep hygiene? regular bedtime, regular rise time. This is a very important thing that sometimes we don't pay as much attention to, but even on weekends, if you can keep your bedtime and your waking times relatively unchanged, adhere to a sleep schedule. Plenty of bright light exposure. We may have heard of something called SAD, or seasonal affective disorder, and that would be individuals who experience depression, especially during the winter months. And for those folks, light therapy, bright light that they sit in front of, can be very helpful. So bright natural light exposure, preferably in the morning along with exercise, that really gives your internal clock, what we call your circadian rhythms, a real chance to stay healthy. Avoiding stimulants, of course, is kind of common sense, and anything with a stimulant will affect your sleep later in the day. So avoiding caffeine and so forth, as I've listed here. I thought this was interesting when I did my research for this talk. One of the items was avoid thoughts or discussions about topics that cause anxiety, anger, and frustration before bedtime. And certainly with all the turmoil that we're currently experiencing, there's the opportunity for a lot of spousal debates about various things. And you don't want to be getting into a political discussion after dinner or before bedtime in any case, because that'll just get you riled up. So, kind of, you want to think mellow as you're heading towards bedtime hours. As I said previously, a definite bedtime routine. Some folks will take a warm bath or a glass of warm milk or a light snack, but eating a heavier meal around bedtime is not a good idea. That's a bad idea. Reserve the bedroom for sleeping and for other sexual activities, and not for laying in bed and watching TV. You need to have cues associated with going to bed which encourage restfulness and sleep. If you do nap, and I don't think a power nap is a bad thing at all, but take it before 3 in the afternoon. And if you are prone to sleepiness after lunch, perfect. Take a 15 or 20 or 30-minute nap, but you don't want to nap so much that you're actually going to render your own self an insomniac because you're not tired later in the day. So, light activities, relaxing music, and so on. All right, this is just more of things that you can do. For some folks, they need to wear one of those masks over their eyes that, to really shut out any ambient light. If you're living in an apartment or condo situation, or if you have noisy neighbors, then earplugs might be helpful. Avoiding exercise within 6 hours of bedtime, very important. One of the things that I had wanted to show you was a TED talk that I pulled off of the internet, and it's a doctor who specializes in sleep at UC Berkeley, and he advocates two main things. One is to keep a regular bedtime and getting up schedule, as I've mentioned already, but he also mentioned the second thing being the temperature of the room. And this researcher recommends that your room be set at about 68 to 72 degrees. Now, for a lot of us, that would be kind of chilly, but he encourages us to have a cool environment, as this is helpful for sleep. I think that's worth trying if you'd like. Satin sheets in the bed helps you to kind of get in and out, helps you to move around. Cutting out your evening fluids, nothing 3 to 4 hours before bedtime to avoid waking up to go to the bathroom. Go to the bathroom before you retire, or a bedside commode can sometimes be helpful. Bladder medications may be needed for those folks that have overactive bladder and that's waking them up multiple times through the night. The other thing is individuals who urinate multiple times through the night need to be checked for diabetes because one of the first signs of diabetes can be a phenomenon called nocturia, which is multiple episodes of urination through the night. This was the gentleman that I mentioned, Dr. Matt Walker at UC Berkeley, really emphasized the importance of regularity, keeping to a schedule, even on weekends, and keep your room cool. 65, I said 68 to 72, but actually it's 65 to 68, pretty cool. Over-the-counter sleep medications I've listed here, diphenhydramine or Benadryl is probably one of the most common over-the-counter sleep meds. But there are a couple of others, and we'll talk a little bit about melatonin, which can, in some individuals, help to bring on sleep. There are a number of prescription sleep medications. I'm not a big sleeping pill fan at all, for a number of reasons. Many folks have heard of or have been prescribed Zolpidem or Ambien, and that's just one of a whole handful of medications that can be taken to encourage sleep. I'm just not a big sleeping pill fan because unfortunately all too often it becomes a requirement, and then you've kind of habituated yourself to needing these medications at bedtime. Any of the medications that end in PAM or PAM, these are all benzodiazepines, and thus they're in the Valium family. Lorazepam being one of the most common. Alprazolam is a common anti-anxiety medication. Any of the PAMs are potentially addictive and habituating, so I try to avoid those. What I may try would be one of the antidepressants, which actually helps with sleep. Doxepin and trazodone are two of the antidepressants which can be helpful, and they're not addictive. What I usually use personally, and it's just my choice, is if a person with Parkinson's needs something to help them sleep at bedtime, and we've tried other non-prescription things, then I will try quetiapine, or Seroquel is the brand name. Not addictive and safe to use. But I try to avoid using anything pill-wise at bedtime. Specific things to Parkinson's disease with respect to sleep disorders. Vivid dreams and nightmares commonly occur in those individuals if they're taking Parkinson's medication at bedtime, and if they don't need to take it, as again, I usually tell folks that a dose at bedtime is a waste of a pill. So if a person's having nightmares and vivid dreams, sometimes just discontinuing their Parkinson medication at bedtime can be quite helpful. But there are other medications. You know, I'm a big one at cutting down the number of pills that people, it astonishes me sometimes when I see a patient and I look at their med list. It's like, holy cow, you know, this is way too many pills. And sometimes you can't, there's nothing you can do about it if it's not needed for cardiac or, other, ailments. But gee whiz, many times there's just too darn many pills. Again, most PD patients don't need PD meds at bedtime. Now, one of the specific phenomena that occurs with respect to Parkinson's disease are these Rem sleep disorders or dream reenactment disorders. Certainly Rem sleep disorders occur in non-Parkinson patients, but they are more common in Parkinson's disease. And research is suggesting that if we go back in the history with an individual Parkinson patient and probe, well, when did you first ever note, or ask the spouse, when did you first notice, okay, you've been married for 40 years, when did you first notice that your spouse was very busy or very active or very restless when they're sleeping, that they're talking and moving and basically dream reenactment types of behaviors? And we're finding more and more that the onset of the sleep disorder, the REM sleep disorder, can occur years or even decades before the onset of the motor symptoms. So even before the diagnosis is made, we may find REM sleep disorder. Mayo Clinic studies had shown up to 2 decades prior to the onset of the motor symptoms of Parkinson's, which begs the question, could a REM sleep disorder actually represent the same brain pathology as Parkinson's disease? So we now know that there are prodromal symptoms of Parkinson's, that is the non-motor, not tremor, not stiffness, not slowness, but other non-motor symptoms, which I've listed here. REM sleep disorder is one, loss of sense of smell is another, may occur years before the motor symptoms. Other symptoms include these autonomic. The autonomic nervous system is your internal nervous system, and it regulates things like body temperature and heart rate and blood pressure and so on. Autonomic symptoms like chronic constipation, erectile dysfunction, low blood pressure upon standing, that's called orthostatic hypotension, bladder dysfunction, sweating abnormalities. Another is depression. These are things which may have their onset years and years before the diagnosis of Parkinson's is made. Going back to REM sleep disorder, is it a Lewy body disease? And the Lewy body is this thing that you can see, hopefully you can see here on the left of your screen, is a slice through an area of the brain called the midbrain, or the part of the brainstem, and those black lines that you can see, those are that is the substantia nigra, where dopamine is produced. The slice below that, you can see that those black lines are much less prominent, and that's due to the fact that those dopamine producing cells have died off. And in the middle, the top frame shows the dopamine producing cells. There's a lot of them. They're kind of big and black, and the bottom, they're bleached out. And to the right, that pink round thing, that sphere, is that's a Lewy body. And the Lewy bodies were first described by Dr. Lewy in 1910 when he was working for his doctorate. And the Lewy body was subsequently found really just in the past 20 years to be composed of an abnormal protein called alpha-synuclein. So Parkinson's disease is a alpha-synucleinopathy. That is, the Lewy body, which is the characteristic pathological finding of Parkinson's disease, is made up of alpha-synuclein. We all have alpha-synuclein. However, in Parkinson's, it's abnormal alpha-synuclein, and it's clumped together, clusters together into aggregates that we call the Lewy body, and it's associated with neurodegeneration of those dopamine-producing brain cells. Well, could it be that a REM sleep disorder is an early finding of this alpha-synucleinopathy, which we subsequently term Parkinson's disease? Now, going to some other specific problems with Parkinson's, restless leg syndrome, very common in Parkinson's disease. The thing about restless legs, it's not actually the movements that characterize restless legs, it's the urge to move. So typically a patient goes to bed and they can't fall asleep because their legs get the heebie-jeebies. It's an irregular and uncomfortable feeling in the legs, inside. It feels like it's creepy, crawling, kind of uncomfortable feeling, and it is relieved by moving the legs. So they get up and walk around, pace a little bit, and that will relieve that restless legs discomfort. The actual leg jerking that occurs in the absence of a need to move, but involuntary leg jerks are called periodic leg movements of sleep. We used to call it nocturnal myoclonus. And periodic leg movements may not be the result of restless legs, although they're commonly seen together. There are medications that help both of these disorders. I just saw a patient the other day and I put him on a low dose of long-acting ropinirole for his restless legs, and it just worked like a charm. So treatments can include actually all of the Parkinson medications, as well as something called clonazepam or Klonopin, which can be quite helpful. Sleep apnea, it's not more common in Parkinson's, but it's just plain common as we get older. And that would be typically obstructive sleep apnea. Some of you folks may have heard of CPAP, CPAP, which is continuous positive airway pressure, and wearing this mask can help keep your breathing tubes open. Evaluation for sleep apnea is done with a nighttime sleep study, and typically treatment is implemented by a sleep specialist. Excessive daytime sleepiness is common in Parkinson's. If it's very severe and the patient's sleeping daytime and nighttime, that makes me to be worried about some of the atypical Parkinson syndromes or Parkinson plus syndromes, of which diffuse Lewy body disease is one. All Parkinson medications can be sedating. They shouldn't, because they're not narcotics, but Parkinson medications can make you sleepy. It's usually dose dependent. So if a person is sleepy after taking their carb levo or after taking their Requip or Ropinirole or Mirapex, what have you, then if we reduce the dose, sometimes we can get over that and they're not as sleepy. There are sometimes medications that we'll use for excessive daytime sleepiness. CNS stimulant or central nervous system stimulants like Ritalin, Adderall, Provigil, and so on. I don't like to give patients more pills to get over the side effect of another pill. So I'm pretty conservative in this regard. One of the things I want to touch on is deep brain stimulation and sleep. My subspecialty is deep brain stimulation, and we've got studies now that show that deep brain stimulation actually helps individuals with sleep disorders. So we wouldn't do deep brain stimulation for a sleep disorder, but let's say a person's got Parkinson's and they really aren't responding to medications, or there's too many side effects, or they just want to get off of all the pills, then deep brain stimulation is a great option. And we find afterwards that they're sleeping better. DBS can be quite helpful. This is a gentleman, just to show you real quick, with Parkinson's there on your left, and he's got pretty bad tremor. He's got all of the Parkinson's symptoms. At this point, he's probably into Parkinson's about 10 years. He's taking 23 pills a day for his Parkinson's. And despite that, he's really quite severely impaired. He really can't even get up out of a chair without help. And he uses one of those quad canes, one of the 4-poster canes, to get around. This guy's like 62 years old at this point. And so that's him before deep brain stimulation. This is him after. And on your right, this is 1 month after deep brain stimulation, and he's on no medications at all. And as you can see, he's able to get up and move quite easily. And we were able to reduce his medications from 23 pills to 3 pills. And his sleep was remarkably better after this surgery. So anyway, that's kind of a quick rundown. I want to make sure we've got time to talk about, and this is me. I'm at St. John's in Oxnard. I also have an office in Camarillo. Parkinson's is my thing. My subspecialty is deep brain stimulation. I was professor of neurology at the Medical College of Wisconsin for years, and have moved out here to be with our wonderful granddaughters, my family. So anyway, we're loving it out here. I'm really enjoying developing my Parkinson practice here, and look forward to perhaps seeing some of you folks. Or if you have any questions, I think this would be a good time to maybe take some questions.
Yeah, thank you so much for that presentation, Dr. Heiner. We do have a few questions, and I just wanted to remind everyone, we're also going to have a question and answer session at the end. So everyone keep those questions coming, stick around, and we'll do that after the second speaker, Jennifer. So the question that we have received most often here is, the questions about the OTC medications like melatonin and Benadryl. Are there any, habit forming side effects or any other side effects that you might not advise to use those over-the-counter medications?
Well, they are not habit forming. That much I can tell you for sure. So the problem with the over-the-counter medications is not because they're addictive or habit forming. They are not. But the problem with them is they have their own peculiar side effects. And in fact, the over-the-counters like Benadryl or diphenhydramine can have an effect on your short-term memory. So you have to use them cautiously and be aware that side effects may be problematic. So short-term memory impairment, but also dry mouth, blurred vision, trouble urinating. They have their own side effects. Melatonin is pretty much side effect free. Unfortunately, it really doesn't work very well. Melatonin has only been proven to be helpful for folks that have what's called sleep lag, or if you're traveling from one time zone to another time zone and your sleep cycle gets off, then melatonin has been proven to help folks who have jet lag. And so pilots sometimes benefit from taking melatonin, but to use it as a sleeping pill, my experience has been that it's 50-50 at best, but none of those over-the-counters are addictive.
Okay, great. We also had a question about managing pain at night. So I think more questions about sort of what can be done with pharma. How can we manage our pain at night if that is disrupting our sleep?
Well, if the pain is from Parkinson's, then Parkinson medications can help. Having said that, pain is not usually caused by Parkinson's. It can, but it's not usually. Most patients with Parkinson's, if they've got a painful disorder, I don't look at the Parkinson's as much as looking at other causes of pain, pinched nerves, or just because you have Parkinson's doesn't mean you can't have all of the other things that we get as we get older. Things wear out, and you get arthritic joints, you get spine degeneration. And so the first, pain is a symptom. Pain is non-specific. Pain can be caused by a whole slew of different causes. And so you don't just treat pain. First thing you do is try to figure out where the pain is coming from. And then you treat that. Try to get to the root cause of the pain, as opposed to just throwing pain medications at it. I'm not a pain doctor, and if somebody comes to me because they've got a lot of pain, I'm probably not the guy to go to. Again, Parkinson's is not usually a painful condition, but Parkinson patients can certainly get pain like everybody else from a whole variety of different things. One tendency I see all too often is for doctors to fall back on blaming Parkinson's for everything. You've got, symptom X, Y, or Z. Oh, that's your Parkinson's. Go talk to your Parkinson doctor. Where in point of fact, maybe it's pain due to a pinched nerve in your spine, or some other cause of pain. So anyway, that's kind of my take there. It probably doesn't answer your question as much as you'd like, but these days we are very strongly encouraged not to use pain medications. And in fact, if you fall and break a hip, you're going to get narcotic pain medications, but they're going to be cut off sooner. I mean, we're very aggressive now, for better or worse. It's kind of, in some cases, I think it's kind of overdone. And I think we're denying some patients their, right to have good pain control. But we're very cautious about it these days.
Great, thank you. So if we're experiencing pain, maybe we want to ask for a referral to a pain specialist to investigate something maybe outside of Parkinson's, and then, okay, got it. I have a question here from Patty Jenkins. Hi, Patty. Thank you for joining us today. Are REM and RBDs the same? So her loved one had violent episodes of acting out, and she's heard that a lot in her support group.
Yes, they are the same. Yeah, so the terms that are interchangeable, Rem Sleep Disorder is interchangeable with RBD, which is REM Behavior Disorder. They're the same. When you have sort of the more violent expressions of REM sleep disorder, then those folks may really need to be on a medication, and the best medication for REM sleep disorder is clonazepam. Unfortunately, it is a medication that also has its own problems, like addictive potential. Clonazepam is a benzodiazepine like Valium and Librium and lorazepam and Ativan. There's a whole slew of them. But if a person has, bad REM sleep problems, then Klonopin or clonazepam is a first choice.
Great. Again, thank you. So just a quick reminder, we are going to have a Q&A at 2:15. So keep those questions for Dr. Heiner coming, and we will have an open long Q&A at 2:15. So thank you again, Dr. Heiner. We appreciate it.
Okay, you bet.
All right. So now I'd like to welcome Jennifer Parkinson Iljin. Jennifer is a person with Parkinson's, a registered nurse and the founder of Neuroboxing, which is a nonprofit that incorporates non-contact boxing, fitness with functional training and yoga. So we're going to hear some more about those mindfulness strategies that people were asking in the chat. Welcome, Jennifer.
Thank you so much. Okay, so like I said, I was diagnosed very young, started having a lot of the symptoms of Parkinson's, tremor, trouble walking, trouble writing, and eventually I was diagnosed with Parkinson's in 2005. Okay. So a few years after I was diagnosed, I started progressing quite a bit. Trouble walking, I was having a lot of freezing episodes. And so about 4 years into my diagnosis, I went through a divorce. And then I also had to go on disability and leave my career as a nurse. So at that point, I started boxing. I had found out about a boxing gym that was local and started training with a trainer. He's an 8-time world kickboxing champion. And I started noticing that my energy level was starting to improve. I was starting to move better and a little bit easier. And I was starting to be able to play with my kids again, which I had never been able to do since they were born. So over time, my symptoms began to improve. And I got to a point after about a year, the diagnosis, where many of the physical symptoms were barely visible. So at that point, I decided I wanted to start a program that would help others in the community. And that's when I started Neuroboxing. So now Neuroboxing has 8 locations in California, and we are beginning to grow. Hopefully after the pandemic, we'll be able to start growing into other states and communities. We now have a completely online virtual program where we offer boxing, cycling classes, circuit and hit type classes, as well as for our Stronger Women classes. This past year, we were offering many education presentations like this one, We've had music from Toad the Wet Sprocket. We've had stand-up comedians as well as a mindfulness series. And then this year we plan to offer a yoga series. We're going to do some art workshops, and as well as our outdoor classes. So we're looking forward to being able to offer a lot more in the coming year. As I said, I've been diagnosed for 16 years, and I just got married for the second time in 2019. My kids are no longer young kids running around. They are now 17 and 20. So I feel like I almost made it. As soon as my son graduates high school, that was my goal, is to get my kids through school. So today what we're going to do is we're going to talk a little bit about different types of exercise. While my focus for the last 12 years has been boxing, high intensity, vigorous exercise, we do offer other complementary therapies like yoga and mindfulness, and those are all great therapies, and they work in different ways to help us benefit not only from combating the symptoms of Parkinson's, but also how it benefits a better quality of sleep. So we're going to talk a little bit about each of those different types of exercise, and then we're going to get up, move around a little bit, and I'm going to show you a little bit of what we do in neuroboxing, and then we're going to do a quick demo in yoga, and then we're going to end with a mindfulness meditation. And hopefully you can get in, you'll start to feel nice and calm at the end of the program. And if you want to take a nap, you can get it in before 3 o'clock. So, okay, so we're going to talk a little bit about the benefits of high intensity exercise. So that's going to be things like boxing, spin, cycling, and those HIIT classes, those high intensity interval training. Okay. Any high intensity vigorous exercise, which we term as forced intense exercise, can significantly improve the neuronal activity and delay progression of Parkinson's disease, correlating with an improvement in patients' quality of life, according to the recent study that I have shown you here, high intensity interval training. It also helps improve your strength, improves hand-eye coordination and reaction time. When we're working on the mitts and the trainer's calling out different punches, it's making you work, your brain work a little bit harder, improving your posture, your core strength. We work on voice work, and again, stimulating those cognitive processes. Also the footwork, balance, and agility. When we do the neuroboxing demo, and I'm going to show you a little bit about what we do, various things in our classes, you're going to see that you're going to be using your whole body, okay? So when we get up to do these exercises, you can do them standing, you can do them seated. Anything that we do is going to be able to be modified and adapted to someone who has Parkinson's disease. So everything we're going to do today, you can totally do it seated. But just know that if you are someone who has never done any exercise, you can do these exercises today. If you are someone who's been exercising for the last 10 years, you can use these types of exercises and then increase the level, increase the pace, and you're going to get a good workout as well, okay? The next type of exercise is spin and cycling. That's something that we've been doing as well through Zoom, is the spin classes. Now, not everybody's going to have a spin bike at home, but we just allow everybody just to use the kind of bike that they have. Some people have recumbent bikes. Some people have a stationary bike or a spin bike. And then other people have a foot cycle. So they're just using their feet, but then they're using weights while they're doing the foot cycle. So they found that people with Parkinson's who pedaled at a high rate of speed for 40 minutes, 3 times a week, saw a 35% reduction in their symptoms. This is from various studies from the Cleveland Clinic and founder of Pedaling for Parkinson's. It may help improve your overall movement, tremors, rigidity, aerobic capacity, cognitive function, and mood. Like I said, you can use different types of bikes. A stationary recumbent bike is going to be better for someone who is has their mobility that's more challenged. Solo biking, it would caution if it's good for somebody who has balance and can ride safely. But another great thing that people can use if they're going to do biking outdoors is a tandem bike. That's where you have a trainer or the care partner is going to be in the front and the person with Parkinson's is behind. That's another form of forced intense exercise, just like boxing, where that trainer is pushing the person with Parkinson's to move a little bit faster than what their normal pace would be. And they have found improved motor symptoms improvement with both boxing and for tandem biking as well. So how does exercise, intense exercise, affect sleep outcomes in Parkinson's? So there was a study, trial of exercise on objective and subjective sleep in Parkinson's disease. The goal of the study was to assess the effects of high intensity exercise rehabilitation using resistance training and body weight interval training. This is compared to the other group who was only using sleep hygiene control. So those are the things that Dr. Heiner was talking about earlier to help with this, with our sleep. Efficiency was measured by a sleep study, measuring the brain waves, oxygen level in the blood, heart rate, breathing, as well as their eye and leg movements from baseline to the post 16-week intervention between the two groups. So how does high intensity impact sleep? So many people with Parkinson's are going to experience sleep disorders, reduced quality of life, depression, worse motor disability. High intensity exercise can improve sleep efficiency, the total sleep time, well, that's your sleep duration, and then that time spent in slow wave sleep, that's that deep sleep, non-rapid eye movement sleep, as well as the wake after sleep onset. So therefore, we believe that exercise, especially high intensity exercise, can be a great non-drug, non-pharmacological treatment. So participants in the exercise group had a significant improvement in sleep efficiency compared to those in the sleep hygiene group. Changes in motor symptoms were not a significant predictor of sleep outcomes. Chronic exercise improved sleep efficiency compared with baseline. The same effects were not seen in acute exercise, meaning short-term exercise. So it's really important to have that long-term regimen, regular exercise. There was also improvement in the exercise group in total sleep time, wake after sleep onset, and the slow wave sleep. There was also a reduction in the use of sleep medication compared to the sleep hygiene group. There was a significant improvement in subjective sleep quality in the sleep hygiene control group compared to the exercise group. All right, so we are going to go ahead and start. We're going to do a quick neuroboxing, about 5 minutes. It's a little bit about, some of the exercises that we do in our class. You can stand for this or you can be seated. A little word of caution: if you have any problems with low blood pressure, dizziness, don't do anything where you're going to be bending over, okay? If you're unsure about your balance, use a chair for support, or just stay seated, okay? And then if you have any back issues, don't twist or rotate your spine or your trunk, and have a family member assist you. So those are good considerations anytime you decide to do an exercise at home program, okay? So let's go ahead and stand up. Again, you can have a chair. I have a chair right here that I always keep right in front of me. So if I need that help or support, I'll always have something in front of me to help. So we're going to start off, and all I want to do right now is go ahead and you can stand up, use that back of the chair, and I just want you to come up onto your toes, just up and down onto those toes. So maybe we can go ahead and stop share for a moment so you can see me. There we go. That's better. Okay. So go ahead and come up onto your toes. If you don't need the support, that's fine, but go ahead and have that chair in front of you if you need it. Come up onto your toes. If you're seated, all I want you to do is just stay in the chair. And all I want you to do is just you're going to come up onto your toes while you're seated. Okay, so just bring those toes up, bring those calves up. Everything we do can be modified. Okay. All right, so now we've got you moving a little bit. I want you to take your feet on a nice wide stance, and we're just going to come down into a slow squat. Come down almost like you're sitting down into that chair. So squat down. There you go. And if you do happen to have a chair, go ahead and sit down into that chair. You're going to sit down in that chair, sit down, and stand back up. If you need to use your hands to help you move from that standing position, go ahead and use your hands. But the goal is to keep your hands up and just stand up without that support. There we go. Now we're going to start with some of our punches. So you're going to have your hands right up here by your face, and we're going to start with that left jab, left jab. So just bring that left hand right out in front. And again, you can do all of this sitting down. So if you happen to be sitting down, go ahead and start. Hands up here. Bring that left hand straight out in front of you. Good. That's it. I want to see all of you doing this. Come on. I can see you on the screen. There we go. Good. Now we're going to bring in that right cross now. So we have our left jab and our right cross. Left jab, right cross. Left jab, right cross. So we're just jab crossing. Jab crossing. Like I said, just start off nice and easy. That's it. Start off nice and easy with those jab crosses. Keep going. Oh yeah, I see you guys now. That's it. Very nice. That is awesome. All right, now we're going to go back to that squat again. We're going to do those squats. There you go. Ready to come down to that squat, just like you're sitting down into a chair. And again, use that chair if you have it. Actually sit down into the chair and stand back up again. Good. Sit down, stand up, sit down, stand up. Good. All right, let's go back to those jab crosses again. Back to those jab crosses. That's it. Keep it going, keep it going. All right, now we're going to go back to sitting down again. Sitting down or doing those squats. Again, if you're standing, we're just going to do those squats. That's it. This can be as low impact or as high intensity as you want it to be. If you're in my classes, I better see you guys going squats and right back into those jab crosses again. Come on. All right, now back to those jab crosses. That's it. And back to those squats. Just standing up, sitting down. Good. Now, the other thing you can add into this, of course, I can't hear you guys, so I'm going to assume you guys are going to be really loud for this. All right, so we're going to squat, and then we're going to come up, and we're going to punch. 1, 2, 3, 4. We're going to sit back down or squat, stand back up. 1, 2, 3, 4. Okay, so everybody start. And then that squat. 1, 2, 3, 4. Squat. 1, 2, 3, 4. Squat. 1, 2, 3, 4. All right. I can see your mouth move on the screen, so I'll know if you're doing it or not. Okay, keep going. About 30 more seconds. You guys got this. I see a lot of you guys moving. Nice. Nice work. Keep it up. Keep it up. You got it. Don't stop now. We're going to add one more thing to this. We're going to do that squat. 1, 2, 3, 4. Then you're going to do 2 jumping jacks. So 2 ways to do this. You do a jumping jack, or you're going to do a range of motion jumping jack, meaning you're just going to do the actual arm motion and foot motion, but without the jump. Okay, so squat down. 1, 2, 3, 4. 2 jumping jacks. Okay, ready? This is your last one. Let's do this. Squat down. 1, 2, 3, 4. And then that jumping jack. Squat down. 1, 2, 3, 4. Doing that range of motion. Jumping jack. Good. Last 20 seconds. You guys got it. Keep going. Jumping jacks. 1 squat. 1, 2, 3, 4. Jumping jacks. 10 seconds. Start our countdown. 9, 8, 7, 6, 5, 4, 3, 2, 1. All right, you can sit back down. We're going to try and really quickly talk about the rest of what I wanted to talk about. Okay. If we don't get to all the slides today, I will. I know that Sarah's going to share the slides with you guys with all the links. Okay, so we'll do as much as we can. So I'm going to try and quickly go through some of these things. The next thing that I think is really important is the benefits of yoga. Yoga is really important for our flexibility, strength, range of motion, hand coordination, cognition. Definitely improves your mobility and flexibility, improves your balance and gait, while also reducing the risk of falling. It may help reduce anxiety and depression, which I believe with any type of exercise, that's going to be true. The biggest thing I want to tell you about yoga is that yoga can be adapted. No matter what anybody tells you, you don't have to get into a twisty pretzel-like position to do yoga, okay? If you can't get down on the floor, if you can't do a standing yoga, there's lots of things that you can do in a seated position. There's even postures you can get into while you're still lying down in bed before you're getting up in the morning. So there's a lot of different things that can really help you no matter what position you're able to get into. Really want to focus on poses that strengthen the core, really work on your posture. Anything that can help with countering those rounding of your shoulders, the forward stooping position, gentle hamstring warm-ups, lateral stretches, and then standing forward, standing in a forward bend, which can be difficult for some people. So again, everything needs to be adapted to what your specific needs are. And that's, if you don't take anything else from today, make sure that, again, you're working with somebody, a trainer who is qualified to work with Parkinson's, or working with a physical therapist, or a specific program for Parkinson's, because that is really the bottom line, is that you need to be able to tailor the needs of your exercise program for you, okay? So in a study conducted by Yoga Biomedical Trust in London, 94% participants saw a reduction in anxiety after performing yoga each morning, and 82% said it helped their insomnia. If morning yoga is not your thing, you can consider adding a bedtime yoga routine. And that's really what I really wanted to focus on, was the fact that while high intensity exercise is going to help you with your long-term benefits to combat your physical symptoms, cognitive symptoms, it's not what you want to do at 9 o'clock at night. Okay, so when you're trying to prepare your body for calm and prepare your mind for sleep, it's really important to do things like more of a gentle yoga or mindfulness. So performing any kind of gentle yoga poses at night will kind of signal your brain it's time to go to sleep. Okay. So I know we're not going to have time today to get into the yoga demo. I would like to just talk to you really quickly about Yoga Nidra. Yoga Nidra is yogic sleep, and it's sort of a guided meditation practice. It's typically done while lying down. And they've really had a lot of really good research and benefits for people with Parkinson's disease, not only with mindfulness, but specifically for Yoga Nidra. So I did include a link here that, like I said, Sarah will share this, and you can go to this link. It's a 22-minute Yoga Nidra, and I'll give you a chance to be able to try that out for yourself. Then, I did want to just quickly talk to you guys about meditation and mindset, and how it's very important to really feel like you have some sort of control over the disease, control over your body, and control over just your everyday activities. And so I think sometimes we kind of get into this mindset of, there's nothing I can do. I haven't slept in years. Nothing's going to help me. I've tried everything in the world. But maybe there are some things that you do have control over. Like, I think, like for me, when I get up in the morning, I don't have control over how tired or fatigued I'm going to be that day. I don't have control over if my meds are working well. If I have more off episodes that day, or if I'm going to be able to cook a meal for myself. But I do have control over some things. I have control over how much water I drink today. And because of that, that means that maybe I can get my medications to work a little bit better, because I'm going to drink more water today, and maybe by tomorrow, I'm going to feel a little bit better. And having that bottle beside my bed so that I don't have to go downstairs to get that water in the morning sets my day up a little bit better. Going for a short walk, even if it's to the living room, even if it's out to the backyard, even if it's down the street with my husband. I can choose to be able to do that. I can choose to eat a healthy meal, even if I can't prepare it or cook it myself. Maybe a family member can help me. Maybe if a family member isn't able to or isn't around, I can have a healthy meal delivered to my door. And then the other thing I have control over, even though I don't think that I do have control over it, is I can turn off the electronics before bedtime. I don't have to scroll on social media. I can turn off my phone. I can set the timer on the TV so that it goes off at a certain time. And all of these things make for just a few little things that I can do every day that I get to have control over. So that's, I know we're kind of short on time here, so, but I will go ahead and, like I said, Sarah can share these slides with you so you can have a chance later on to read through these and go to some of the links. And that is really all that I have, so.
Thank you so much. We really appreciate that. And I know we all got a little movement in too, which is great this afternoon. So thank you so much, Jennifer. Okay, so I have everybody's questions. If I'm only sleeping 4 or 5 hours at night, can I take short naps during the day? Is that helpful? You know, what do I do if I can't sleep that 7 or 8 hours? Do you advise to not try to nap during the day and try to sleep longer at night, or just go ahead and take the nap? What are your thoughts on that sleep schedule?
Well, I think one of my slides addressed that. I'm not against power naps at all. So if you take a snooze after lunch for 30 minutes, even up to an hour, I don't have a big problem with that. The recommendation is usually not to nap after 3 p.m. So try to get your power nap in before 3. But, you know, it gets to be problematic when a person is sleeping, or, you know, their nap is really 2 or 3 hours of sleeping, and then they can't fall asleep at night. Well, then you need to like deny yourself that long nap in the day to try to reset your sleep-wake cycle. And that may take a while, you know, and we see this in shift work a fair amount, where somebody's, you know, on a schedule that may vary from, you know, AMs to afternoons to night shift. And that's a tough problem. But for the Parkinson patient who is having trouble falling asleep or is waking up at night, limiting your daytime napping to no more than 30 minutes and always before 3 in the afternoon would be wise. You don't want to get you know, something that I've seen many times is people get their sleep cycle kind of turned around. So they're sleepy during the daytime and they're up at night, you know, and so to try to reverse that, you have to deny yourself that afternoon nap. And for that to take effect can take up to 3 to 4 weeks. So it's not like, okay, I didn't take a nap today, but I'm still having trouble sleeping at night. Well, you got to stick with that recommendation for a good, you know, really a month to get your sleep-wake cycle. This is a, you know, it's a circadian rhythm, one of your internal clocks. To get it turned around can take really sticking with a regimen for up to a month. So easier said than done.
Right. Yeah, and so we actually have a lot of questions about DBS, since you mentioned, you know, that is your
Wonderful.
subspecialty. Yeah,
Wonderful.
I know it's a good topic, and so, you know, we're keeping it relevant to sleep here too. People are asking, you know, anecdotally, they've heard that DBS can help with fatigue. Have you seen this in your patients? Do you think DBS does help with sleep?
Absolutely. I mean, and the way that it helps is it's not, a complex issue. Simply put, if your Parkinson's symptoms are made significantly better, then you're going to get a better night's sleep. The way that I sort of conceptualize DBS as if Parkinson's is a slow decline. I mean, actually the slope of that decline varies from person to person. But if it's kind of generally a steady loss of dopamine producing neurons in your brain, what Parkinson's does is it takes you back up that slide 5 to 10 years. So it resets your body. It literally rejuvenates your Parkinson so that it acts like it did 10 years ago. It doesn't cure your Parkinson's, but it pushes you back up that dopamine ramp so that you don't need as much medication. And being able to cut your meds down, and I'd say on average 50%, sometimes even completely, although that's rare, but being able to reduce your medication requirements, that's good for you. I mean, that's a good thing. So I have absolutely had the experience of a patient with Parkinson's having DBS done, and they're just better. They sleep better, they do better, and so forth. But I want to be clear about one thing, which is DBS is not for everybody. It's not something that we do just sort of without putting a lot of thought into it. But when it's right, when it's a good option, then the results are just outstanding. I mean, I can't tell you how many patients will tell me down the road, boy, I'm glad I had that done. Or it wasn't, a common thing is it wasn't as bad as I thought. You hear about brain stimulation. Boy, that sounds pretty rough, but it's really not. The procedure itself is really fairly benign. The patient is awake during the procedure, so I can be interacting and talking with them, and I can be, I've got my hands on the patient throughout the procedure, so I'm able to assess, how things are going with their Parkinson's, and it's just so gratifying in the operating room to see a person's Parkinson's improve within really minutes of activating the stimulation. We see, it's just a blast for me as a practitioner where I can actually make a person, if they've got tremor, I can make that tremor stop within a matter of minutes once we've implanted. If a patient has a lot of rigidity, cogwheel rigidity, a lot of stiffness, I can make that, I don't want to make it seem like I'm doing it, but when we activate the device in the operating room, I can feel that stiffness melt. It just goes away. It's so dramatic, and patients feel that. It's like, I have them do various tasks, while we're doing the procedure, and you can see them regain fine motor skills. Commonly we'll do finger tapping and hand opening and twisting and so forth. And to see that actually improve right before your eyes, and the patient says, yeah, I can tell, it feels much easier. So anyway, that's a kind of a long response, but I'm very, to me, deep brain stimulation, there have been a couple of revolutions in the treatment of Parkinson's disease. The first revolution was when Dr. Parkinson described patients, and his descriptions are absolutely fantastic. They're so right on the nose. So that's the first big thing. The second thing is the discovery of the Lewy bodies in 1904 by Dr. Lewy. And then the third thing is the discovery that dopamine is the problem, not making enough dopamine. And that was in the late 50s or early 60s by some researchers in Sweden. And they were the first to say, hey, the problem in Parkinson's is the dopamine producing brain cells have died off. So those are the three big milestones. The additional milestone that I think has provided the biggest change in our approach to Parkinson's is in fact deep brain stimulation, because pills will only take you so far. And while we encourage patients to, I mean, the best thing a patient can do for their Parkinson's is exercise. And certainly what Jennifer was talking about with yoga, I mean, that's been proven. You know, that's not like an iffy thing. Studies in the New England Journal, which is kind of the preeminent medical journal, this is 10 years. There was an article on Tai Chi and Parkinson's. I mean, it's proven, it works. So the best thing patients can do is to have a regular and vigorous exercise program. The more, the merrier. If it's just taking a brisk walk 20, 30 minutes a day, then that's it. But if you can do more, great. And Tai Chi, yoga, absolutely. Proven entities. But at a certain point, if the medications really aren't doing the job, or you're simply taking too much pills and you want to get off, you want to do something definitive, then that's where this most recent revolution is, which is deep brain stimulation. And it's just you know, it's not equivocal, it's not iffy. In the right patients, it can be really quite remarkable. But the key thing here is in the right patients. It's not the most common cause, or one of the most common causes for failure of deep brain stimulation is improper patient selection. And if patients are not being diagnosed properly, there are things that can mimic Parkinson's disease, the atypical Parkinsonian or Parkinsonisms. If a person isn't correctly diagnosed as having standard classic, what we call idiopathic Parkinson's disease, then DBS is not going to work. And that's where you get people who don't get that improvement that I'm talking about. And the second reason is if that DBS lead, or the stimulating electrode, if it's not exactly right on, I mean, it's got to be placed with high degree of accuracy. And when it is placed accurately right in this spot, which for most Parkinson patients is something called the subthalamic nucleus, which I can locate within a sub-millimeter, I mean, within fractions of an inch accuracy. And if you get it in that right spot, you're going to get good results. If somebody doesn't have a good result, it's either because they shouldn't have had it in the first place, or it wasn't placed in the exact right spot. Anyway, that's kind of my take on that.
Thank you. I think we know what we want to do for the next program for this Ventura market is DBS. Thank you so much, Dr. Heiner, for this, really insightful information. We have to wrap. We're actually at time. We have a book that we shared in chat, which is on DBS. We also have a sleep book for all of you. You can use that link and access it online. We want to thank Dr. Heiner, Dignity Health. We want to thank Jennifer Iljin and Neuroboxing. I also want to acknowledge Patty Jenkins of the Ventura Parkinson Support Group. She's on today, and we shared her email as well. She's wonderful. Thank you for joining us. Our sponsors, Supernus, Adamas, Kiowa Kirin, Boston Scientific, and Amneal. So these are the people that make this happen. So we encourage you to check out our chapter supporters page so that you can learn more about them. And then many thanks to everyone for attending. Again, this has been recorded. We're going to put it on the YouTube channel. You'll get the link. If you had a question, we had a lot of questions that were about speech therapy and of course the DBS questions. Call our helpline. They're amazing. Email them and look on our website for more information. We want to thank you again for joining us, and stay safe until next time we meet. Thanks.
Thank you.